collection of neutrophils, edema fluid and cell debris. The collection of all this is called pus or purulent discharge. Any localized collection of pus is called a abscess. This may be superficial or it may be deep in the tissue. This is caused by seeding of the infection deep into the tissues. Suppurative inflammation may be caused by pus producing bacteria, for example streptococci. They are called pyogenic organisms. Here you see a subcutaneous abscess which is opened out, and you see skin, subcutaneous tissue. This is pus and necrotic tissue. It's a subcutaneous abscess. This is an example of suppurative inflammation. If you take a look at the histopathology, this is also a H&E stained slide where you see a lot of tissue edema, cell debris and neutrophils, along with the RBCs which are sequestered here. The last type of morphology that we see is a ulcerative form of acute inflammation. An ulcer is nothing but a gap in the lining epithelium. A breach or a gap in the lining epithelium is called ulcer. Obviously, it has to occur on the surface or the lining mucosa of an organ. This occurs because the inflammatory tissue necroses and sloughs away, leaving an ulcer. This is the crater or the ulcer in the duodenal lining. You can see this is the lining mucosa and it is interrupted. So this crater here is the duodenal ulcer. The base of the duodenal ulcer shows a sprinkling of neutrophilic cells here. So this is a duodenal ulcer. Now let's look at chronic inflammation. In chronic inflammation, the inflammation is of a prolonged duration. In chronic inflammation, tissue destruction, active inflammation and attempts at repair are carried on side by side. Chronic inflammation has an insidious onset, the progress is slow, and the repair is usually by fibrosis. This is the underlying pathology behind very common chronic diseases like rheumatoid arthritis, atherosclerosis, tuberculosis, syphilis, etc. Let's look at the causes for chronic inflammation. Causes may be a persistent infection, especially with certain organisms like Mycobacterium tuberculosis or MTB. This acid-fast bacillus causes tuberculosis. This is a chronic disease. Another organism which causes a chronic disease is Treponema pallidum. This causes syphilis. This causes syphilis. Both these elicit a delayed type of hypersensitivity reaction. Granulomas are characteristic of this type of inflammation. We'll come to the explanation of the granulomas when we look at the chart. Next cause for a chronic inflammation is a prolonged exposure to the noxious stimulus. These prolonged exposures may be to a exogenous stimulus. For example, people who work with sand or silica. These exogenous noxious stimuli may trigger off a delayed sort of hypersensitivity reaction in the lung, leading to a chronic inflammation of the lung called silicosis. Then there may be endogenous substances which may act as a noxious stimulus for chronic inflammation. For example, in atherosclerosis sclerosis. Here, the endogenous plasma lipid content acts as a stimulus for chronic inflammation in blood vessels, especially in large arterial walls. This predisposes to the formation of atherosclerotic plaques inside the arterial walls. Next, you have a reaction called autoimmunity. This is a cause for chronic inflammation. Here, antibodies are produced against self-antigens, or autoantigens perpetuate an antibody response leading to tissue destruction. Most common and famous example of this disease may be systemic lupus erythematosus or SLE. A lot of other connective tissue disorders also come under this category. This picture shows you an inflammation in the lung. This is an acute inflammation, as in bronchopneumonia. This is a chronic inflammation of the lung. Here, the alveoli, the structure is preserved. There is a neutrophilic infiltrate both within the alveolus and in the margins or the walls of the alveolus. A lot of tiny RBC collections are seen as blood clots. These tiny red dots are RBCs seen sequestered inside the alveoli. But the basic architecture of the alveolus is preserved. If you take a look at this picture, this shows you chronic inflammation. There is necrosis of the alveolar tissue. The basic structure that is maintained here is destroyed here. So that's the first point in chronic inflammation. Destruction of the tissues, number 1. 2. Attempts at healing characterized by the presence of these fibroblasts seen by these arrows. And the third thing is the kind of cells that are present in chronic inflammation, which are lymphocytes and macrophages, in contrast to the cells here which are neutrophils. So these are the differences between chronic and acute inflammation of the lung. The cells which mediate chronic inflammation are macrophages, lymphocytes, mast cells, eosinophils, etc. Let's look at the most important of them all, macrophages. Where do they come from? The bone marrow produces the progenitor cells called monoblasts. They mature into the monocytes in blood. The half-life of these monocytes in the blood are only 1 day. But these, when they go to the tissue, they turn into macrophages. They are transformed into these specialized cells with a longer time frame, several months to years. These tissue macrophages may live from several months to several years. These tissue macrophages are called by different names in different tissues. They are called Kupffer cells in the liver, osteoclasts in bone, alveolar macrophages in lung, and microglial cells in CNS. These monocytes may be transformed into tissue macrophages, or they may be transformed into activated macrophages. This chart shows you the interaction between macrophages and other leukocytes. Activated macrophages, as we have seen, which come from the blood, elaborate substances like interleukin 12, and they activate T lymphocytes. These T lymphocytes in turn produce other inflammatory mediators, and this sets off a cell mediated immunity. These activated T lymphocytes may produce interferon gamma, and they act on other macrophages and recruit them by activating the other macrophages. These activated macrophages have another function where they present a foreign antigen to the T lymphocytes. This is a crucial step in cell-mediated immunity. Activated macrophages also elaborate certain other factors like TNF or tumor necrosis factor, IL-1 or interleukin 1, and other inflammatory mediators, and they help in chronic inflammation. Now let's look at a specific type of chronic inflammation called granulomatous inflammation. This is specific type of chronic inflammation characterized by granulomas. Granulomatous inflammation have a focus of active macrophages surrounded by mononuclear leukocytes. These mononuclear leukocytes and the active macrophages inside take on the appearance of epithelioid cells. Granulomas have a focus of active macrophages surrounded by a collar of mononuclear leukocytes. Sometimes they may also have a band of fibrocytes surrounding them. This happens in long-standing granulomas. There are two types of giant cells that you may see in granulomas. One is a foreign body type giant cell. Two, Langhans type giant cell. Here, these epithelioid looking cells form one large cell with multiple peripherally arranged nuclei. This is a Langhans type giant cell. In foreign body type giant cells, the cell is similarly large, but the nuclei, instead of being arranged peripherally, are randomly arranged. This is a foreign body type giant cell. This is seen in TB or tuberculosis. This is seen in sarcoidosis. There are other diseases which are characterized by the formation of these granulomas. For example, syphilis, brucellosis, cat scratch disease, etc. In syphilis, these granulomas are palpable under the skin and they are called gamma. Gamma is singular, gammae is plural. This is seen in syphilis. Now let's look at the histopathology picture of tuberculosis. This shows a central area of caseating necrosis characteristic of TB. This is the area of necrosis devoid of any cells. There is a dispersion of epithelioid cells and mononuclear macrophages around this area of central necrosis, interspersed by these cells which are called Langhans type giant cells. They are giant cells with peripherally arranged nuclei. So this is the feature of tuberculosis. Central caseous necrosis, a collar of macrophages, Langhans type giant cells, and if you take a look towards the corner, these are fibrocytes. It has a rim of fibrocytes surrounding it. The systemic effects of inflammation. We have acute phase reactions characterized by fever and the production of acute phase proteins. Fever is present when you have an acute inflammation. There is a rise in temperature from 1 to 4 degrees centigrade, and this could be caused because of pyrogens, which may be exogenous like the lipopolysaccharides of bacteria and other microbes. Endogenous pyrogens may be Interleukin 1 or tumor necrosis factor. These are pyrogens which cause a fever in the acute phase of inflammation. Then there is a production of acute phase proteins which may be C-reactive protein, fibrinogen and serum amyloid A protein. The acute phase proteins are C-reactive protein, fibrinogen, serum amyloid A protein. Then there is leukocytosis, which is an increase in white blood cells. This leukocytosis is within the range of 15 to 20,000 cells per cubic millimeter of blood. Sometimes the response may be very severe to the infection, and it may run in the range of 40 to 50,000 cells per cubic millimeter. This sort of reaction is called a leukemoid reaction because it looks like a reaction seen in blood cancer or leukemia. Therefore, it's called a leukemoid reaction. In acute inflammation, the cells which proliferate or which are the predominant cells are neutrophils. Therefore, there is usually a neutrophilia in acute inflammation. As more and more injurious substance is exposed to the various factors in the blood, there is a large amount of release of precursor cells of these neutrophils from the bone marrow. Therefore, if you take a blood picture, there is a left shift or a shift towards the left. This is characteristic in acute inflammation. Then there is lymphocytosis. This is seen particularly in some diseases like infectious mononucleosis, etc., where instead of neutrophils, there is a predominance of lymphocytes. Then there's another reaction in infection that the count of the lymphocytes falls. This is called leukopenia. This occurs in certain infections like tuberculosis, when there is a rampant TB, or disseminated cancers. For other effects like tachycardia, a rise in BP, you can have somnolence, anorexia, etc. because of the action of interleukin 1 and tumor necrosis factor probably on the brain. All these are systemic effects in acute inflammation. Let's take a look at the chart. These are the major effects of interleukin 1 and tumor necrosis factor in inflammation. Bacterial products like LPS or lipoprotein or lipopolysaccharides present in the bacterial cell wall, other immune complexes, toxins, physical injury, and especially cytokines activate the macrophages. They elaborate substances like interleukin 1 and tumor necrosis factor, which have a role to play in fever, increased sleep, decreased appetite. There is production of acute phase proteins, for example, C-reactive protein, fibrinogen, etc. There are also hemodynamic effects. There may be a large scale